Hello, my name is Kim Eagle from Ann Arbor, Michigan. I'm very delighted to be with you today covering the first day of the ACC 24 National Scientific Sessions in Atlanta, Georgia. We're covering some of the very important trials at this meeting today. I'm joined by several notable colleagues who are experts in clinical trials. Payal Kohli from Denver, Colorado, Dharam Kumbhani from Dallas, Texas, and Ajay Kirtane from New York City. There are so many trials to cover, but we're going to pick three to talk to you this morning about. And I want to start with AEGIS II. Ajay, tell us about this study.
Well, first of all, thanks so much for having me. This was an ambitious trial, 18,000 patients aimed at looking at a new hypothesis, basically a hypothesis that you could improve cholesterol efflux. Remember, HDL, not just in terms of its number, but in terms of its function, can bring cholesterol away from the arterial wall. And the reason I think it's ambitious is most lipid-lowering therapies have looked at agents and their effects over a long period of time. These were patients who came in with myocardial infarction, about a half STEMI, half non-STEMI, and treated with 4 weekly infusions of this agent, ApoA1, and looking at 90 days to see if there could be a reduction in cardiovascular death, MI, or stroke. That's ambitious, and unfortunately, the trial did not meet its primary endpoint in terms of showing a reduction. However, although if you looked over time, particularly through the follow-up period to a year, there were some trends that seemed to emerge perhaps in favor of this drug and the hypothesis that improving HDL function could reduce clinical outcomes. Look, the trial is negative in terms of its primary endpoint. There will be sticklers out there who just interpret the data that way. Very interesting subgroup of patients that had elevated LDLs at baseline did have a statistically significant reduction in the primary endpoint. So in my mind, this hypothesis is not dead. I think it's certainly worth investigating. And I do commend the investigators for doing this type of trial to look at after the point of care of an MI. Could you induce a drug to improve cholesterol away from the wall and then change clinical endpoints? So I think there'll be more to come from this study.
Thank you, Ajay. I agree. 18,000 patients enrolled. It's massive. One would think that perhaps if there was longer follow-up, perhaps there would have been effect with effects on plaques and vulnerability later, but time will tell. There's another study being released today that I think has a wonderful name. It's called VICTORION. Payal, tell us about this trial.
So thanks, Kim. And the Victorian trial actually builds upon the Orion trials, which looked at inclisiran, which is an siRNA that targets PCSK9. So remember, siRNAs are small interfering RNAs. They work upstream of the protein. They work from the messenger RNA to the protein. So what I really love about this trial is that it really changed the way that we think about lipid treatment, because so much of what we're doing in lipids, we know what we're supposed to do, right? Get that LDL down, get it down quickly, and get it down for longer. And yet, for all these complex reasons, clinical inertia, access to care, we're unable to do it. So in this phase 3B trial, what they did was use upfront inclisiran as a treatment for patients who had LDLs greater than 70 milligrams per deciliter as the threshold, or non-HDLs greater than 100, and then follow them out to 330 days to see whether or not you got that LDL down, and also looked at, interestingly, statin discontinuation. Now, this was an open label trial, so you knew if you were getting inclisiran or you were getting usual standard of care. But what they saw, not surprisingly, if you got inclisiran up front, and that's twice a year after you get those first 2 doses at 0 months and 3 months, you go every 6 months, you got your LDL down more. So more people got below 55 and more people got below 70. But the part that was really surprising to me was that despite the fact that in the usual standard of care, their LDLs were not coming down, these patients had ASCVD, there was not intensification of statin therapy, really sort of highlighting the problem. In fact, there was a pretty high rate, about a 17% rate of statin discontinuation. So to me, this trial has really changed how I'm thinking about lipid lowering in my patients. Combination therapy upfront aggressively can get them there faster. But a few words of caution. As we know, inclisiran obviously has good early data, but the outcomes data is not yet out. So certainly something to think about. And in the expert consensus decision pathway, it does suggest preferential use of the PCSK9 monoclonal antibodies because they have longer safety and efficacy data. But I'm hoping that this trial is a wake-up call that we got to do better with statins, and also helps us to really think about that early aggressive, hit those plaques hard, hit the LDL hard, try to get it down early.
Great. Love your coverage of that. we sort of are paralyzed by the way the new drugs get introduced, aren't we? We know this one works, and we add this and we that. And these investigators said, wait, let's look at this completely differently. Let's get that LDL down right away with an agent that we know works and seems to have benefit. And I love the thinking in this trial, and there's a lot more to be learned for sure. There's a trial being released today also that I liked a lot. It's called RELIEVE-HF. Dharam, tell us about that study.
Yeah, thank you. This was a very exciting trial. So as you know, we know in patients with heart failure, both in patients with reduced ejection fraction, as well as in those with preserved ejection fraction, the LA pressures tend to increase with exercise. And so that is one of the drivers for these patients having exertional symptoms. So there's been a lot of interest in investigating the role of intra-atrial shunt devices, particularly among patients with HFpEF. And we've seen, a couple of trials already, and there are several others that are ongoing. So this is, again, a device trial using the V-Wave device in patients with both HFpEF as well as HFrEF. And so this was, a pretty big undertaking. They included 500 patients across multiple sites, and they stratified by ejection fraction. So they included patients with both HFrEF, defined as an EF of less than or equal to 40, or patients with HFpEF, that is patients with an ejection fraction greater than 40%. And then they were randomized to receiving this device, which is basically a self-expanding platform. It has a right atrial disc and a left atrial disc, typically results in a QPQS, a shunt fraction of about 1.2 or so. And, what they were looking at was both safety and efficacy. So they met the safety endpoint, and there were really 0 events. And so that was really good to see. Unfortunately, they did not meet the efficacy endpoint. So their primary endpoint was designed as a win ratio, which we're seeing increasingly in contemporary trials. And the win ratio did not show a significant benefit in favor of the intra-atrial shunt device. I'm sorry, I should have mentioned the comparison arm was actually a sham control. That is also something that has been really good to see, in device trials, particularly of late. And so they did not see a benefit. Now, interestingly, there was evidence of significant interaction between the two strata. So patients who had HFrEF, or reduced ejection fraction, appeared to benefit primarily with a reduction in heart failure hospitalization, whereas patients with HFpEF actually showed worsening outcomes with the device implant. And there was also concerningly an increase in mortality in the device arm. So I think, what we don't know from this trial is this a failure of the device or the technology? Because as I mentioned, particularly among HFpEF patients, there are many ongoing trials. So I think this is something we'll have to keep an eye on. I think, of course, the subgroup analyses have to be viewed in the context of an overall negative trial. But I think, this mortality signal is particularly concerning and something we'll have to keep an eye on in ongoing trials as well.
Thank you, Dharam. I agree with your conclusions. The differences in those two arms by EF was just absolutely striking, and certainly makes one think that a separate trial looking specifically at HFrEF, the trial may be positive in that circumstance. Also encourage our learners to take a look at STEP-HFpEF Dm. We're on a roll with the GLP-1 agonists and their benefit across various strata in cardiovascular care. This looks at patients with diabetes and HFpEF, and again, striking results in these agents that seem to have primary cardiac effects, not just diabetes, not just weight loss. So the ACC, Saturday, April 6th, lots of great trials. I want to thank Payal, Ajay, and Dharam for covering these really important late breakers today, and wish our learners a great day on this first day of ACC 24. This is Kim Eagle for ACC.org, and I'm out.